Welcome back to the Saving Sapiens podcast. I'm your host, Matt. Today we're going to be doing the first solo episode, and we're going to be talking specifically about an article that I published in 2024 on the science of genetics and what it has to say about human ancestry. This article was published in Sapiens Anthropology Magazine, and it specifically addresses the idea that in the historical practice of medicine, there has been a practice of racializing diagnostic and therapeutic medical interventions, and the concept has broadly been based on the idea that there's an assumed biological basis for race, and this implies a genetic difference between peoples who are classified into different racial categories. Now, the science in biological anthropology and genetics is overwhelmingly, decisively clear in stating that this notion of race is incorrect. It is an unscientific claim to suggest that there is a biological or genetic basis for distinctions between racial groups. What we're going to do today is we are going to read this article and comment on sort of expanding some of the ideas here and addressing why they are important. If you are joining on Spotify or you are listening, feel free to just listen along. If you are watching, please feel free to follow along with the article. The article is Doctors Are Taught to Lie About Race. The subtitle: Decades ago, anthropologists dispelled the myth of biological race. Lagging behind in scientific understandings of human diversity, the medical profession is failing its oath to do no harm. Doctors lie daily. The moment a patient enters our care, a simple checkbox starts the deceit. By checking patient's race, we healthcare providers pretend to know something that we cannot possibly know: the patient's ancestry and associated medical risk. Now, the intro to the paper addresses the first part of a patient's experience, and thankfully, there are a number of medical systems across the country that are no longer participating in this kind of data collection. This is why this is problematic. When a patient enters a clinic, the information that they're trying to give the physician should be informing what the physician knows about them and their health. If, for example, a physician asks, "Do you have a history of smoking cigarettes?" This is a very clinically relevant piece of information. Why? Well, it's a clinically relevant piece of information because if you have been smoking cigarettes for a long time, then you are likely to have a higher risk of certain forms of oral and lung cancer. But if a physician were to ask, "Are you African American? Are you a Caucasian individual? Are you an Asian individual?" These categories suggest that they are helping inform the physician about your relative disease risk. And that would only be true if there was a biological or genetic basis for such categories. And as we're exploring today, this is not only problematic, this is already in the realm of unscientific myth. Continuing reading. While studying to become a physician, I was one of the lucky few who had the chance to also study human genetic evolution and its impact on health. Topics missing from most medical curricula, but central to fields such as biological anthropology. I was struck by an alarming dichotomy. Genetics and anthropology scholarship have unanimously refuted a biological basis for race. These fields understood that racial categories used today in the US were not the result of scientific investigation. Rather, they were invented centuries ago as part of a violent European system that colonized and enslaved non-Europeans. Yet the MD coursework, clinical training, and even medical literature reinforce the antiquated notion of sorting patients according to skin tone. That is, white, black, or other loosely defined racial category. When it comes to race, the US medical system has fallen decades behind the rest of science. By perpetuating unscientific racial sorting, medical professionals are failing patients and medicine's oath to do no harm. When we use racial categories to evaluate, assess, and treat patients differently, we mask the real reasons why medical outcomes vary among racial groups. That is, no patient ever became ill because of the biology of their race. It was the impact of racism all along. Now, the point here in the paper thus far is to acknowledge that there are very real health disparities between patients who are categorized into different racial categories. The objection is to the notion that we can assume it is the fault in biology differences between those categories of patients. If there is no biological basis for such different health outcomes, this tells us that the differences are coming from something that should be changed in society or in the way that patients have access to healthcare or in something else, but not something that we can attribute to fundamental biologic or genetic differences for which the patient carries the difference that causes this difference in outcome. That is the myth that we're unpacking. The myth of biological race in medicine. During medical school, mentored by two experts in biomedical informatics and evolutionary medicine, I buried myself in scholarship, generally absent from medical school. How the evolutionary pressures that shaped humanity contribute to modern disease patterns. I learned about the impact of viruses on the human genome and spoke at conferences about how our evolutionary past made us subject to diseases in modern environments. Fundamental to this work is an understanding that genetically speaking, human races do not exist. Now, for those of you who thought that the basis of human race was genetic clusters, this may come as a huge surprise. There's no genetic basis for human racial groups. That is the fact of human genetics. In fact, if we cluster human haplogroups, it turns out that all humanity originally comes from Africa. All European, all Asian, all Native American groups all trace their ancestry to African haplogroups. It is impossible then to treat African ancestry as a separate genetic cluster when all of humanity comes from Africa. If we look at genetic clusters, the way that groups cluster in no way reflects modern racial groups. The modern racial categories that we have today are a social construct. They're groups that people have come up with on their own, not as the result of shared genetic differences. Now, one way to think about this is if you think about basketball teams. Basketball teams are a social construct. It doesn't mean basketball teams aren't real. Basketball teams are real. They're just real because we have socially agreed that we are sorting people this way. Basketball teams aren't the result of, for example, clustered shared ancestry. Basketball teammates are not more closely related to each other than they are to their families. Now, we might say that basketball teams are really tall, but even that tallness isn't the result of actual shared ancestry. Back to reading. The very notion that one could segregate people into groups that roughly approximate ancestry assumes those ancestral groups have remained separate throughout history. For many people subjected to, quote, black and white racial sorting in the US, that historical proposition is false. Their ancestry crosses continental boundaries, sometimes at multiple points over centuries. Beyond all of this, even the hypothetical ability to identify patients with predominantly recent African ancestry would not indicate disease risk based on genetics. The reason lies deep in human history. Now, the importance of this part of the paper that we just read about the crossover between historic groups, the shared and mixed ancestry of so much of the population in different parts of the world, and especially in the US, is incredibly important, because what it means is that when a physician sees a patient and might be inclined to assume a particular ancestry, that cannot be accurately done. When a physician sees two patients sitting next to each other and assumes that they are both black, the physician may be looking at one patient who has 90% African ancestry, and the patient next to them, who they also believe is black, may have 21% African ancestry and 79% European ancestry. If there were a genetic basis for differences in disease risk based on the percentages of ancestry relative to each continent, the very fact that looking at different people and assuming they're part of the same group when they could have a 50, a 60, a 70% difference in their relative ancestry is profoundly demonstrative of just how absurd and superficial racial categories are that are often used to inform medical decision making. This is why we should reject, in part, this is why we should reject it. And the rest of the reasons why we should reject this model are based on even further understanding of human ancestry. Continuing the article. The diversity of African ancestry. Homo sapiens, that is our species, arose in Africa roughly 300,000 years ago. Groups leading to most present-day people outside of Africa only began their global spread around 60,000 years ago. Humanity, for most of its existence, lived and died in Africa. Outside of Africa, all the human haplogroups, clusters of shared genetic variations inherited from shared ancestors, descend from African haplogroups, a finding we would expect because humanity arose in the continent. All of the haplogroups outside of Africa descend from just one of the multiple haplogroups inside Africa, a testament to the dramatic reduction in genetic diversity that occurred when people spread out of Africa. It is haplogroup L3 in case you want to impress friends with genetics trivia at a party. Today, genetic diversity within those who live in Africa continues to measurably exceed the genetic diversity of people outside Africa across half a dozen metrics of variability. These data lead to a conclusion that would undoubtedly surprise many physicians. There are fewer genetic differences between a European and an Asian patient than there are between two randomly selected people of recent African ancestry. It is less inappropriate to generalize about the genetic makeup and health risks shared by two African descent patients than it would be for shared risks between an Asian and a European patient. We have an illustration here, a wonderful illustration demonstrating that European and Asian genetic diversity is a subset of African genetic diversity. You cannot pretend to be practicing medicine based on racial sorting in which African ancestry indicates a different, distinct set of shared risk factors from other patients like European or Asian ancestry, when in fact European and Asian ancestry are themselves a subset of African ancestry. Now, this part of the paper so far, we have discussed the nature of genetic diversity and how the ancestry for the rest of the world that migrated outside of Africa actually clusters from within Africa. This is enormously important for the study of human diversity because it means that the majority of human diversity is inside of Africa. And this is a great moment to talk about actual shared homologous risk factors. When people have shared homogeneous ancestry from a small bottlenecked ancestry, it is possible to talk about some degree of shared risk. If a couple of individuals were to give rise to an entire group of people, like if you had great grandparents who migrated, just the two of them, onto a small island, and then they proceeded to have kids who had kids who had kids by intermarrying among the descendants of just that one couple, then that would be a serious bottleneck and a very small genetic pool. And the low diversity would mean that there could be shared disease risk in that population that descended from that bottleneck. In fact, the entire world, to some degree outside of Africa, had some degree of bottlenecking in the ancestry of that population. But Africa itself has the most genetic diversity, and therefore the racial sorting practiced in the West of separating Black and white patients as if they are different risk categories and assuming that Black patients, for example, have higher risk, is itself as far away from the realistic genetic data as one could possibly get. Continuing reading. In a special case, ancestry does signal elevated health risks. Groups with extremely reduced genetic diversity. People in these populations may descend from a small initial group of ancestors and or mainly reproduce with fellow members of an insular community. This, of course, is referring to long-term endogamy, marriage within a group. Well-studied examples of such genetic isolation include Ashkenazi Jews and some populations in South Asia where in-group marriage prevails. Because in these cases, parents are more likely to share rare genetic disorders, ancestry is indeed predictive of certain diseases and conditions, such as Tay-Sachs disease among Ashkenazi Jewish people, or butyrylcholinesterase deficiency in the Visacea community of South Asia. This predictive power does not apply to broad African ancestry, the most diverse gene pool. Socially determined disparities. Being labeled Black does not reliably indicate African ancestry, and African ancestry is too diverse to indicate shared genetic risk. And yet, in the US, more Black people die early from treatable conditions and suffer from chronic diseases, including diabetes and heart disease, compared to white people. Researchers outside of the medical practice understand why. The consensus among biological anthropologists and public health scientists recognizes that racism drives these inequalities rather than imagined race-related genetic differences. As a leading professional group of biological anthropologists put it, while race does not accurately represent the patterns of human biological diversity, an abundance of scientific research demonstrates that racism, prejudice against someone because of their race, and a belief in the inherent superiority and inferiority of different racial groups affects our biology, health, and well-being. Scientists at the Centers for Disease Control and Prevention have linked health inequalities to non-biological factors, the so-called social determinants of health, including healthcare, education, economic stability, and environmental exposures. At the same time, doctors, nurses, and other medical professions carry false beliefs that worsen racial health disparities. In a now famous study published in 2016, about half of the medical students and residents involved reported a range of biologically false beliefs about racial differences in patients, such as, quote, Black skin is thicker than whites. Now, note that these are profoundly harmful, false beliefs held by people with a medical education. This should alarm people at the deepest level, because when institutional differences exist in how patients are treated, When social differences from the time a person is young to the time they're old exist in the access that they have to everything from education to safe places to live to the kinds of food that are available. When these differences exist, they drive social determinants of health in opposite directions for people who are socially categorized into different groups. Continuing reading. While many providers would never consider themselves to harbor racist intent, it is the presumed innocence and assumed scientific origin of these beliefs that makes them so dangerous to patients. Black patients literally pay the price for the pseudoscience of racialized medicine when their pain is ignored or undertreated. In the study, the medical providers endorsing racially biased beliefs recommended insufficient pain treatment for Black patients injuries. These beliefs contribute to the disturbing fact that Black pregnant people are more likely to die from complications during pregnancy and childbirth, despite the absence of any genetic basis for risk differences. In 2021, for every 100,000 live births, nearly 70 Black mothers died compared to about 27 white mothers. In part, this is because healthcare providers often treat Black pregnant people differently, monitoring them less frequently and dismissing their symptoms. The risks extend to world-class athletes and Black women wealthier than any hospital CEO. In a medical system ruled by racism, even Serena Williams and Beyonce face risks that have no basis in biology. In this part of the paper, I'm addressing the very real existence of racialized health disparities by pointing out that the differences are not to be blamed on biology or genetic differences. We are calling out society to address the kind of social determinants that drive these healthcare inequities by pointing out that healthcare education often fails to correct these pseudoscientific myths from ages past. We're calling out the source of the differences in treatment for patients categorized into different racial groups. Continuing reading. In conclusion, social solutions. It's time for medicine and society to acknowledge the actual drivers of health inequalities between the racial groups assigned by society. It's time to call out the systemic racism. Today, like every day, thousands of doctors will claim their patient's race confers an elevated risk for a host of diseases, precludes certain medical conditions, and precludes certain medications and procedures, and more. Countless patients will think they inherited these risk factors because of their African ancestry. Most patients and providers will have no idea that anthropologists and biologists have resoundingly refuted this notion for decades. Medical students, teachers, and practitioners must catch up with the rest of science. There is no clinical or genetic evidence of biological distinctions between racial groups, and it's time for us to replace our outdated training with up-to-date information. In practice, instead of lying to patients by blaming diseases on their unchangeable ancestry, medical professionals must learn to recognize the impacts of racism and contribute to social solutions to this societal ill. Our patients deserve better. While some medical boards have begun to endorse discarding racialized medicine, change cannot happen fast enough. We owe it to our patients to correct ourselves and our profession. And if all else fails, the population we treat has the right to correct the medical profession the way every other institutional arm of racism has been corrected, from lenders who denied mortgages to realtors who wouldn't sell to certain families in certain neighborhoods via direct legislative intervention. If the medical profession can't catch up to the science and get on board with equality, the public can pressure us to accept that necessary and urgent change. Thank you for joining me on this solo podcast of Saving Sapiens. Today, we addressed a very important part of healthcare inequality, a long-standing difference in the healthcare outcomes and the healthcare challenges that people in minority groups face. The existence and association of this difference with the myth of biological and genetic race. And we talked about human ancestry. In a future episode, we will address some of the absolutely beautiful science that has been done to uncover African genetic diversity. We'll talk about some of the evidence for universal shared African ancestry for out of Africa migratory groups. And we'll cover some other fascinating topics in evolutionary medicine. Next time, we will also be getting back to interview episodes with a fascinating interview with Dr. Sergio Andreu Sanchez as we address the global microbiome studies that have recently been shown to be associated with some absolutely fascinating correlations of aging, cancer, and other human health conditions. I hope to see you there. And thank you so much for joining in on the Saving Sapiens podcast, where we address the crossover between our past and the medicine and breakthroughs of tomorrow. Thank you so much.